Right, good evening, everyone. I see just a few of us are here. Please, can you hear me? Good evening, Dr. Choma.
Good evening, Doc.
Happy Sunday to you. How are you doing today?
I'm fine, sir. Happy Sunday to you too.
Dr. Ngizi, my chairman.
Good evening, sir. I can hear you loud and clear. Good evening, sir.
Thank you so much. How was your day, sir?
It's well. God is helping us, sir.
So we'll just begin the presentation right away. It's already some few minutes past 8 p.m. Sorry. So that we can make good use of the night. I know tomorrow is another very busy day for every one of us. So we'd like to just begin right away so that we can end in good time. So I'm sure you can see my screen and you can also hear me loud and clear. I will also share my video. Permit the lighting here is kind of poor. I have to go to a place where I will not be distracted by the noise. So please permit the video. I'm sure you can see me and you can hear me clearly.
Yes, we
All
can.
right. Thank you. So this evening, we're going to be looking at a very, very important part of eye care that a lot, there's a lot of debate anyway as it concerns management of glaucoma. We are kind of fortunate in this part of the world where we, especially as private practitioners, that we are at liberty to manage glaucoma. Well, some persons may argue that, but at the end of the seminar, we'll be able to know if you can manage glaucoma or not. But one thing I need to make very clear is that there are certain management regimens that is within our scope as optometrists. We may not go into management that involves opening of the eye. However, of course, you and I also know that glaucoma management does not necessarily mean surgery. So our focus tonight is how to manage glaucoma, how to care for our patients with glaucoma, or we can also term or call this presentation or topic it as the guidelines, clinical guidelines for glaucoma management. And my name is Dr. Osazee. I'm presenting this on the biweekly presentation for FCT mentors. And so we'll go very quickly into the introduction. I don't want to bore you about this enigma called glaucoma. It's actually the major cause of blindness globally. It ranks among the very, very leading causes of blindness, and not just blindness, but irreversible blindness. Whereas cataract top that list of blinding or leading causes of blindness, and glaucoma comes second. But in the cause or the leading causes of irreversible blindness now, glaucoma is still number one. And so it's something that has caused a lot of burdens, not just to us as practitioners, but even to the patients as well. And not just the patients, but even the family of the patients. And of course, by extension, the society. because the more blind people we have, the more uh, slow the economy will be. Imagine um, half of the workforce are blind. It means that country will be under siege. Why? Because half of the army is blind, and war will be waged against that country very often, and of course they will easily lose. Half of those in the academia are blind. Half of those in the industries are blind. You see, so it's not something to even think about. Okay, so it has a way of reducing the potentials of the society. And so it's something that is really, really worthy of discourse, worthy of deliberation, and see how, as eye care practitioners, we can help in curbing this menace, as it were. So it's been reported over time that glaucoma patients have very poor quality of life. They have reduced psychological, emotional, even physical, as well as social well-being. And of course, they depend more on others to help them achieve their aim. And so I think enough has been said about this. You and I also know that till date, though there is a lot of breakthrough as it concerns managing this disease. However, there's still not a total 100% breakthrough, as it were, as it concerns, reversing glaucoma. So it's a disease, it's a syndrome. In other words, it doesn't have a syndrome there now means it can be caused by a lot of factors. So we'll look at that as we move on. But in order to diagnose, in order to treat this enigma, where one must be able to have what it takes. And this is the question that we pose to every one of us here. And that is the reason why we must pay attention to this presentation. Some of us may already be practicing managing glaucoma. Some of us may be scared and are oftentimes referred out from our clinic. But as soon as you possess, the skill, I usually let people know, particularly practitioners, that there are two things involved in whether you are capable of handling a disease or handling a disease condition. Number one, is it within your scope? I mean, the scope of practice. So the scope of practice is different from the scope of knowledge or expertise. There are some disease conditions that is within our scope, possess the expertise to address them. Now, this is why this seminar or these presentations is done, so that we brush up ourselves and we help ourselves, remind ourselves of things and learn some things so that we can, stand tall and be proud and also be more confident as we manage some of these disease conditions. So you must possess the skill as well as the knowledge. The question of how to appropriately diagnose, treat, and manage the disease of the vital, not only in maintaining patients' quality of life, but also in stemming the increased burden of society imposed by this disease. Sorry, I hope you can still hear me. My network is unstable.
Yeah, I can hear you.
Thank you.
Loud and clear, sir.
Thank you, sir. All right. I think I've discussed more about it. Let's just move forward because of our time. So this presentation is going to focus on two major types of glaucoma. We have several others, but for the sake of this presentation and the time allotted for this presentation, we're going to be focusing on these two types: the open angle glaucoma, or we call it the primary open angle glaucoma, POAG, and the closed angle glaucoma, or the PCAG, that's primary closed angle glaucoma. The one that is most common is the primary open angle glaucoma. It's most common. I'm sure those of us that have been practicing, even those of us that just started practice very recently, may have come across this type of glaucoma, and maybe managed it or see people manage it. So we already know what glaucoma is. It's actually a group of diseases. That's why we call it a syndrome. It's a group of disease that affects what we call the optic nerve. Now, for those of us that understand the anatomy of the retina, we know that the optic nerve or the optic nerve or the nerve fiber layer is or are fibers that goes through the optic nerve head. Now, the optic nerve head is the connection, of the optic nerve itself to the eye. Now, if you imagine the visual pathway, I'm sure you remind yourself of the optic nerve. So, or the optic nerve. The optic nerve and the optic nerve head is the junction where the optic nerve connects with the eye. So that area is the optic nerve head. Now, the optic nerve itself constitutes the nerve fiber layer, right? And the nerve fiber layer from the anatomy of the retina is simply a continuation of the ganglion cell. So we can say that the axons of the ganglion cell is what continues to form the nerve fiber layer. And the nerve fiber layer goes out of the eye through the opening we call the optic nerve head. It continues and forms the optic nerve. So damage to that fiber or that nerve, that optic nerve head, is what we call glaucoma. And that must be established first before you can diagnose glaucoma. So most of the time, you just suspect, you suspect glaucoma as well. However, if you don't have a fact, if you don't have something that backs up the fact that there's a damage to the optic nerve, you may not be free to call that glaucoma. And we also know that glaucoma, due to its nature, is actually a progressive disease. In other words, if the process has started, it will always end up in blindness. Our job as clinicians is to see how we slow the process down. We can't stop it. Remember, the apoptosis, we call it back then, where you have programmed death. So if the process has started, it must continue. And this is due to the fact that the structure of the nerve, of the neuron is made in a way that if a part of it has a problem, that problem must cut across the whole of the neuron. It's so sensitive a cell that you don't joke with. And that's why to date, brain damage is still one of the most difficult to address, because once the neuron dies, it cannot be replaced. Okay, so that's what glaucoma is. And of course, we all know that it results to blindness. But the point is, how quick is it? That's where we come in. Okay. So, just like I mentioned earlier, for you to be able to diagnose this disease, you must be able to establish some form of functional and structural abnormality. Now, usually the structural precedes the functional. And from research, it's clear that there's a lag between structural defect and functional defect. So most of the time, you may find a structural defect as seen either by your ophthalmoscopy or your OCT. And these are not reflected in a functional test like the visual field. So most times you are still, except you are sure of what you're seeing, because in FOM also there's a module we call pre-parametric diagnosis of a glaucomatous disc. So you don't need most times, you may not need a visual field exam for you to give that diagnosis. That's how we call it pre-perimetry. Okay, so if you're sure of the structural defect you see and it is typical of glaucoma, then you can tentatively say that that's glaucoma and start your treatment. However, for sake of standardization, there must be some form of functional defect before you can boldly say that glaucoma has ensued. Otherwise, you are safe to call it suspicion. So we also know that one of the major signs for the presence of glaucoma is usually raised IOP. However, we have also seen that there may be other forms of glaucoma or other causes of glaucoma. We have ocular perfusion that can also cause some form of damage to your optic nerve. So it's not just IOP or raised IOP that can cause it. And also some other metabolic changes within the eye can also involve the damage to your optic nerve, such as your increase in glutamate levels and all of that. So we're not going into that now. So why is glaucoma difficult to diagnose? Some of us, and this is very sincerely said, not because, not out of pride. I was also at the time guilty of this. You know, for us to diagnose glaucoma, we must have gone to either from moderate to severe stage before it is diagnosed. We hardly, as optometrists, pick up, not just optometrists, let me say eye care, practitioners generally, because this cuts across the board. We hardly pick out early glaucoma, because that maybe we're not very diligent when it has to do with the examination, especially a ophthalmoscopy, we zoom in and zoom out, and we miss a lot of very, very important signs. So let's look at why is it difficult to diagnose glaucoma. Visual fields are also not helpful in the early stages. You see, that's what the simple truth. Remember, I told you earlier that there's usually a lag between structural and functional defects. That study said about 5 to 6 years. So if you have a structural defect, it takes about 5 to 6 years before a standard automated perimetry examination will be able to assess it or identify it. SAP, okay, which is the most common. Though we have other forms of visual field examination that can pick glaucoma early than the usual SAP. And we have SWAP, which is short wavelength automated perimetry, as well as frequency doubling technique. Now, these two can pick glaucoma earlier than your regular SAP. Okay, so, but generally, there's still a lag between the functional and the structural field defect. So that's one of the reasons why you don't diagnose glaucoma early. So you see some, maybe a structural defect, you send for visual fields and it comes out normal, and you're wondering, okay, just let's monitor. Another thing is optic nerve damage is in the early stage is difficult or impossible to recognize. This is very true. However, there's also another module. Okay, I think there's still the same module, that pre-perimetry diagnosis. In fact, if you go through that module, which I think we'll look at in this biweekly presentation, I don't know why we missed it. Maybe that would have come first before this. I'm not sure of the timetable anymore, but we'll definitely look at it. Okay, so there are about 8 signs you look out for when you examine your optic nerve health. And at least if you find 4 out of the 8, then your suspicion for glaucoma should be much more increased. So you don't need to see a very large curve before you say, oh, there's glaucoma here. There are certain other things you look out for. I don't want to mention them here now, but We'll look at that when that time comes. So sometimes it's difficult to diagnose glaucoma at the early stage. Another very, in fact, this is so scary because most 80 to 90% of my patients that are diagnosed of glaucoma usually don't know about it. Okay? So you sometimes you just come for regular checkup. Sometimes they are accompanying their friends, and reluctantly check, and we find that wow, this disc is suspicious. Before you know it, they end up with glaucoma, and so they don't even know that they have it because of it doesn't have symptoms. POAG doesn't have symptoms. Remember, our focus tonight is POAG and PCAG. Don't have the POAG doesn't have symptoms, although the PCAG has its own. But we'll look at that as we move forward. 80% of glaucoma cases is primary open angle glaucoma, and they don't have symptoms. So people usually don't know that they have it. Many people with a high IOP may not have the damage associated with glaucoma. So you may have, of course, we also know that ocular hypertension is different from glaucoma. You may have ocular hypertension. It's just one of those risk factors that could lead to glaucoma. All right, but they're two different things. So when you don't have glaucomatous damage, you may just be treating elevated IOP. 1/3 of the patients with glaucoma do not have elevated IOP. That's also very clear. And this is usually seen in what we call low tension or normal tension glaucoma. That's also another type of glaucoma. However, the question may arise, oh, how do we now diagnose such kind of glaucoma? There are also signs that you look out for. That is why we don't just zoom in and zoom out of the eye when doing ophthalmoscopy or using your 90D to assess it. This we must be particular about certain things. And that's the reason why we are having this seminar presentation. Most of the ocular findings that occur in people with glaucoma also occur in people without glaucoma. So most times you find that you hear of physiological cupping, you hear of pallor. Sometimes you confuse pallor from cupping. These are issues that we must know. I hope that when we look at that pre-parametric diagnosis of glaucoma, what does this, we'll take note of some of these things and learn them. So let's classify glaucoma as it were. It could be primary, it could be secondary, and it could be developmental. But for the sake of this study, because of our time, because we cannot exhaust everything that this slide even has, so I'll just focus on, like I said earlier, primary open angle glaucoma and primary angle closure. So for primary angle glaucoma, it could be, your conventional open angle glaucoma. It could be ocular hypertension. It could be normal tension. While for a primary angle glaucoma, you could have the closure of the pupil or the closure of the angle rather due to pupillary block, and also when the iris is having more or less like a push with a curve, and that curve we call it the plateau, which can actually narrow the angle and can cause a blockage or a closure of the angle. And you can have a bit of them or a mix of them, which is mixed glaucoma. So when you have narrow angles alongside clogging the drainage, so the angle is still open but it's narrow, and this may be due to some form of injury. Although in my experience, when you have an injury to the eye, it leads to what we call iris prolapse or iris tear. And when an iris is torn, the angle is actually more open than closed. Although sometimes the reverse may also be the case, where you have, in fact, when the angle is recessed, that's angle recession or angle tear, the pressure is usually fluctuating. So you could have a high pressure today, you have a low pressure tomorrow, and that in itself can cause the nerve to be damaged. Remember that a steady, in fact, one of research have shown that slightly high but steady pressure can even it's not at risk. It doesn't put one much at risk to having glaucoma than a pressure that is fluctuating. So a pressure that is fluctuating is even much more, or puts one much more at risk for glaucoma. Okay, so pressure is low today, it's high tomorrow, and all of that puts you more at risk to developing glaucoma. Okay, characteristics of ARD, I'll just run through this. It's not our main focus tonight. So when there's thinning of this ring, that's your neuroretinal ring, that will be a characteristic or a sign. When there's nerve fiber defects, of course, using your ophthalmoscope and your red-free filter or your red filter, your red-free or your green filter, I beg your pardon, you can use that to diagnose a defective nerve fiber layer. When you have normal anterior chamber angle, so the angle is open or the angle is deep, it's not shallow. So that's a characteristic of POAG. Of course, ganglion cell loss, that's when you do your ganglion cell complex scan in the OCT. You usually have either gross loss or focal loss of ganglion cell. And of course, visual field defect. Signs of primary angle closure now. So this is different from the primary open angle. So this primary angle closure now. Now here, conversely as it was in the previous case, here pressures are usually very, very high. So you can get as high as 80. In fact, most of your machines or non-contact tonometers may not be able to assess that high pressure. So you can be finding or you'll be hearing errors, error, something like that. So just a moment, please. Just one. Sorry about that. I hope you can still hear me. All right. Did I hear Choma say something?
Loud and
Can
clear.
you hear me? All right.
Yes,
Yes,
sir.
I hear you, sir.
So I was saying that your regular NCTs may not be able to assess that high pressure. So your gold man may be useful, for this kind of pressures. Although even the patient may not be able to allow you because of the excruciating pain. Okay, so you usually anesthetize before you even check the pressures. Now there's usually decrease vision. In fact, there's instant or sudden vision loss. There's usually redness, ciliary injection, dilation, pupil dilation. There's also very, very slow reflex. There's edema because the pressure is high, because there's narrow or shallow angle or closed angle. There's the iris bumping, that's like a plateau, bulging forward of the iris. There's papilledema, some of the times, not all the time. There's venous congestion, there's this hemorrhage. This is when it is not addressed immediately. I think, in my own opinion, PACG is even easier to address. It's easier to manage compared to POAG. The reason is because this one the patient would know. This is not a condition that the patient would live with. If it happens, the patient will look for the nearest eye clinic because it is a pain that cannot be borne. You cannot bear it. It's so bad. I have not had it. But from my experience with patients, it's not something that you can manage. In fact, if it happens at night, you don't mind looking for the nearest eye clinic. It's an emergency. In fact, an ocular emergency. All right, so symptoms increase.
30 minutes.
What is the time? My name is.
So now
So,
4.
Dr. you are welcome.
Started for 30 minutes. What is the time? So
Dr. Oluchi,
5:30
Olivia, you are welcome. Please mute your mind. Thank you.
5:10. There is no.
So let me just try. Okay, she has muted herself. Dr. Oluchi, you're welcome. Okay, so let's continue. So we look at the primary glaucoma. Now the secondary is probably due to the cause. Okay? So it's secondary to, you can have secondary open glaucoma, you can also have secondary closed angle glaucoma. This means that something would have led to that kind of glaucoma. And for the open angle, secondary open angle glaucoma, it could be due to it could be pre-trabecular, it could be post-trabecular, or hyper secretory, all right? Why for secondary angle closure, it could be anterior, it could be posterior. So you could have the closure coming from the anterior angle or the posterior angle as well. So you're looking at synechia, for example, just like you have in synechia where you have anterior and posterior. So for the trabecular form, here there's the resistance of aqueous between the trabecular measure and the anterior chamber. Same with vascular glaucoma. Why for the trabecular, okay, that's pre-trabecular. Why for the trabecular here, it's characterized by resistance in trabecular measure due to prolonged use of steroids. You and I know that that's one of the risk factors for developing glaucoma. It doesn't cause glaucoma. Okay, so let's get that clear. Risk factors are not causal factors. They are two different things. So when one is at risk of developing glaucoma, it's different from when this particular thing is a causal factor. So let's get that. Let's get that clear. So we have the post-trabecular form is due to resistance around the Schlemm's canal. For those of us that understand gonioscopy, you see that there are structures within the anterior chamber angle. So it's not just one, it's not just only the trabecular measure we see. There are other structures there which we'll look at briefly as we move forward. Here, it's accompanied by exophthalmos, of course, some form of increased pressure in the vena cava. It's a type of vessel around the eyeball. And lastly, we have a hypersecretive form, which is secondary glaucoma due to aqueous hypersecretion. So sometimes it could be on some medications that will cause, too much secretion from the ciliary processes of the ciliary body to cause increase. Sorry, I was cut out by network. Can you still hear me now?
Yes, I can hear
Yes,
you.
you're back on, but we've lost the slide.
Oh, you got the slide. Oh, okay. Let me quickly share the screen again. Okay, I'm sure you can see the slide now.
Yes, you can see now.
So I was trying to explain the anterior chamber and the posterior chamber. So the anterior chamber is actually bordered anteriorly by the posterior cornea and posteriorly by the anterior legs. I hope you understand that explanation. Okay. So any issue that happens around that area and it leads to some form of increased pressure, then we call that anterior, or we call that is secondary angle closure, glaucoma anterior. Then posterior is when it happens from, the other side, the posterior chamber. So that's you're talking about the lens, around the lens region, uh, where you have some form of posterior synopia or subluxation of the lens. That could also cause closure within that posterior area. So posterior chamber now is looking at, say, from the posterior lens down towards the uh, uh, retina. Okay? So, however, if you look at the iris around that area, okay, the angle is usually bordered. The anterior chamber angle now is bordered by the anterior iris and the anterior iris and the anterior. Oh yeah, the posterior iris. I beg your pardon. The posterior iris and the anterior lens. So these are the issues. So anything happening within the posterior region can lead to angle closure, is regarded as a posterior cause. While for developmental, here is due to, as the baby or as the child develops in the eye, everything is in the womb. And if there's an anomaly in that process, it will lead to developmental or what we call congenital glaucoma. So this is a table that just related, compared these two kinds of glaucoma, open and closed angle. And some of the things here we've already mentioned, so I'll move on very quickly. The types of glaucoma, in summary, these are the types. So we're not looking at all of them. Time will not permit us to look at all of these. But the focus for this presentation is number 1 and number 2. So this is a focus of tonight's meeting. So I'll just run through this very quickly and we'll close. Well, not this actually, these are clinical tests or diagnosis. Our focus tonight is how to manage it. So I'll run through this, then we go into management. That you and I know all of these tests. These are the tests you do to be able to diagnose glaucoma. So your preliminary test, tonometry, pachymetry, perimetry, OCT, and of course, gonioscopy. So in your perimetry test, all of this, just like your routine tests. Okay, so check for case history, visual acuity, and all of these things as seen in the slide. Now, for case history, some complaints must be paid attention to. So when the patient gives his or her chief complaint, there are certain questions you must ask. You and I know how to refine the patient's chief complaint using your log-C or your ODAC. Log-C there talks about laterality, onset, frequency, time, severity, associated factors, and of course, associated factors. So you must use that to check the chief complaint. And of course, visual loss, there will be check for redness, eudoxia, ocular history, social history, family history, medication history, and of course, allergies, as well as systemic disease. Now, most times, the systemic disease have been associated with glaucoma, where you have diabetes, hypertension. Most vascular diseases are actually linked to glaucoma. However, hypertension per se does not have a direct link, to glaucoma, because some patients will say, "Oh, I have hypertension." Does it mean that is the hypertension that has made or that has caused my eye pressure to increase? The answer is no. There's no direct link between hypertension to glaucoma. However, these patients are more at risk. As I said, they are risk factors. They are more at risk to developing glaucoma. So, of course, for external exam, when you check for external exam, check for redness. Remember, we told you that for PACG, that your primary angle closure glaucoma, you usually have some form of redness. Redness is actually around the cilia, that's ciliary redness. Yes, around the limbal region. That area is really red because there's some form of inflammation going on around the uvula, and that will cause that redness to be there. This may also point out or control IOP due to, of course, angle closure. I've mentioned that already. Yes, another very important test that we neglect is each test, pupillary test. Usually, or of course, this is usually seen when the glaucoma is usually moderate to severe stage, where you have RAPD. So you're having your right afferent pupillary defect, where you shine light in that eye, and it's the other eye will react with that eye, we are all it's giving you an opposite reaction. Okay. So instead of when you shine a light, so light is supposed to constrict, the pupil is dilating. That's an abnormality. Okay. That's what we call an afferent, right afferent pupillary defect. Now you also assess the cornea very, very typically for cases of edema. Of course, edema is seen with closure or usually with very high IOP. When it's high IOP, remember we looked at 2 weeks ago, we looked at corneal hysteresis, and we said that one of the functions of the endothelial cells is to see how it works. We call it the endothelial pump, right? So when there's too much based on osmolarity, when there's too much hypertonic, just try to balance it. Okay, so it releases, it opens up the cornea sometimes for water to go in if there's so much tonicity within the cornea, or the other way around, so that there's a balance. All right. Now, sometimes when there's so much pressure behind, it doesn't have a choice than to see how it reduces the pressure within the eye and opens up the cornea, open up the channels for some fluid to go into the cornea, and that leads to try to help the pressure behind the eye. The cornea becomes edematous. So that's why you see, corneal edema. Now you also check for thickness, which is also called pachymetry. This is very, very important to understand or to get the true IOP. And so you and I know what that indicates. Check the anterior chamber angle for the level of openness it has. So you grade it using your Van Herrick system. If it is open, phase 4, as phase 4 means open and wide. Phase 3 means open, very wide. Phase 2 means open but narrow. Wide grade 1 means still open but very narrow, and of course grade 0 means it is closed. So you check for the anterior chamber, presence of just check that area, and if it is narrow angle, then it's an indication for gonioscopy to see which of these structures are visible. And that will also help you to grade and be sure of what kind of medications to use. If it's to open up the channel or to reduce secretion and all of that. It informs your choice of medication at the end of the day. You also check for exfoliation, check for pigmentary glaucoma, because that's another type of glaucoma, where you had long-standing uveitis that have brought a lot of precipitates, protein deposits, and all of those flares, cells that have settled within the angle and the cause of blockage. Okay, so check for iris mobility. A lot of things you check for. These are quite a number. The list is endless. But trust me, you and I don't do this. I will tell you, and I will be very sincere. Sometimes your clinic can be so busy that you look away. You are not so meticulous to look at these things. Some of us that have not too busy a clinic, you can take your time, especially, or you can rebook these patients for much more, diligent examination. Check for all of these things and be sure that this patient is free from them or they have. Check the lens, of course. Don't think that it's only the disc you check. Check for the lens because it could be secondary. Remember we said subluxation or some form of lens swelling can also result in increase in IOP. Check for the position. Check if there's a contact of the iris with the lens, anterior lens, which we call posterior symmetria. This can also cause the pressure to increase. Also, you check the optics, which is very, very paramount. Check for all of these. There's also more. Check for the type, check for the age, and that's a horizontal and visible CD ratio. In fact, the vertical is even most important. The vertical CD ratio would affect the superior and inferior ring. Okay, that is very, very key, for you to assess glaucoma, because the thickest areas where the red fiber layer is where the inferior, followed by the superior. So if there's any form of thinning around that region, then there's surely, certainly glaucoma. Check for the cup depth. How deep is the cup? How many disc makes the cup or the disc learn? That gives you the cup depth. Check for the cup pattern. What's the cup pattern? Is the cup pattern a double pattern? Does it spherical? Just to check for that. Check for laminar cribosa. Laminar cribosa is those tiny holes or like appearance of the optic nerve head. And that is where the nerve fiber actually goes out of the eye. The pass through tiny holes and goes out of the eye into the brain. That's the laminar cribosa. It shouldn't be seen because it's already covered by bare tissue. Sometimes because of excavation, you find the laminar cribosa at the end of the day, it points out to some form of nerve damage. Of course, new retinal ring, you must also check for that. The new retinal ring is just the border between the cup and the optic nerve head. That area is the ring. You must assess it clearly, especially the superior and inferior ring, because those are the areas that are thickest. If there's anything there, it's not good enough. So Okay, apologies for the break in transmission. Sorry, can you still hear me? Hello.
Yes, I can hear you, sir.
Pardon for that break. I'm actually in the veranda, and so my neighbor mentioned that there's a snake around, so we have to quickly kill it.
Oh.
Sorry about that.
Mm.
And so it's dead. That one don't we don't it has made it work and do. Okay, so let's continue. So these are some of the things you look out for when you look at the optic nerve health. So you check clearly and be sure that some of these things are not there. If they are there, papillary atrophy, the communal barring, all of these things, I wish and I pray that we all are around when we take that module. All of these things will be touched and will be explained very, very in depth. Okay, so these are some of the signs of early optic nerve damage. You have a situation of greater than 0.5, focal thinning, vertical cupping, I stressed that earlier. When you have focal excavation, when you have disc hemorrhage, and when there's a departure from pleasing fluid. Of severe to advanced glaucoma, you're having 0.7 CD ratio, diffuse nerve damage. You have thinning, diffuse nerve thinning, there's gross thinning of neuroretinal. You have the excavation where you can visibly see the cribosa, that's laminar cribosa, and of course there's hemorrhage sometimes. And we say take note of the degree of optic nerve damage, and it helps to initiate or it helps to give you a guide as it concerns the initial treatment. You should also check for the fundus, check for any form of vascular anomaly, check for degenerations and retinal disorders. Photometry, I'll just run through this, though these are areas that we must also pay attention to because you don't just some of us use wrong pressures, and at the end of the day, it misinforms our treatment modalities. We looked at corneal hysteresis last time, and we saw the need, though the machine may not be available here, however, we must be sure of the pressure within the eye before we go ahead to manage. Okay, so when you hear or see a 23 or 28 or 31 millimeters of mercury pressure, be sure that that is what it is, okay, by ensuring that it's not due to thickness of the cornea or due to wrong readings due to your machine. So this is very, very, very important. Now, we always also tell you that before you dilate any eye, it's very key. You also check for the pressure because dilation causes the angles to be much more narrower. And so if it is necessary to dilate, you must be sure that the pressures are okay. And of course, you record the timing because of diurnal variation. Remember, pressures are usually highest in the mornings, and as you go down the day, it drops. So you must be sure. And usually, you tell patients if you're managing the benefits of glaucoma, the patient must come for IOP check at a particular time. You don't just use any. You don't do any time. You don't use. You can't come anytime for IOP check. So, factors influencing IOP measurements, most fundamentals, thin cornea. Thin cornea gives you erroneous reading. Thick cornea, of course, gives you erroneous reading. When it is of TFM, this is very important. In fact, my machine will not take. My NCT will not give you any pressure to just tell you error. So the patient must blink, for enough TFM to be there. And also when it is excessive too, when the patient is tearing, it also gives you some form of error. And when there's edema, it also gives you erroneous reading. That will definitely increase the thickness of the cornea. And when you have had refractive surgeries where the cornea is very irregular, it also gives you irregular reading. Pachymetry, you and I know what it is. It helps you to know the thickness of the cornea. So a cornea that is thicker than normal will give you higher readings than normal. While a cornea is thinner than normal, we give you lower readings. And we always seen that thin corneas are actually puts one at risk for developing glaucoma, because you can have a thin cornea and your pressures are low. So you go to the clinic, they check your pressures are 12, 11, 13, and all of that, not knowing that something is wrong because this cornea is thin. If you actually do documentary and you see, this cornea is around 400 or 400 microns or 350 microns, which is very rare anyways. If you want to be surprised that you're adding over 10 to that reading you have, and that makes the pressures higher than normal, above 51 millimeters of mercury. So we check for visual field. Okay, we're already on perimetry now. So this is also another area that is deep. We have a whole module on this. Now, like I mentioned earlier, the regular SAP does not check or does not diagnose glaucoma early, but the SWAP, which is a short wave automated perimetry, can actually test for glaucoma early. And of course, the FDT, which is a frequency doubling technique, these have been shown to diagnose glaucoma on time compared to the regular SAP. So this is just a flow chart that shows you what to do if you have normal fields. If there's a normal field and you have a structural anomaly, there's no structural anomaly, then there's of course no glaucoma. That's what we see here. So normal field, there's structural abnormality. There's no structural abnormality, then there's negative diagnosis, so there's no glaucoma. If there is a structural abnormality, then you will test if the structural abnormality is clinically relevant. Now, for borderline visual fields, if there's structural abnormality, if there's no structural abnormality, you will test if the abnormality is clinically significant. If you have a structural abnormality, then there's a positive diagnosis, so that is glaucoma. If the field is abnormal and you don't have structural abnormality, then it may just be an artifact. If something is causing that field to be abnormal, maybe cataract or some form of opacity, media opacity. So you need to retest and be sure that that is what it is, or use other tests. Okay, so that's what we mean by this column here. You use other tests to confirm what you have. But if the structural abnormalities, if there's no structural abnormalities, then it could be other causes, and of course you test. However, if there's structural abnormalities, okay, then it is, if there is structural abnormalities and it's due to other causes, and if it's not due to other causes, you will test. If it's due to other causes, it's a negative diagnosis. So if it's due, for example, to, if your abnormal field is due to cataract, it's not glaucoma. So you can't call it glaucoma. However, if it's due to, if there's a structural abnormality, all right, then you can call it a positive diagnosis. And that structural abnormality is not due to other causes, and of course, it is glaucoma. Staging of visual field effects. We've said here over time, although that's the module on perimetry, particularly when it talked about recent development in perimetry. Here you talk about staging and facing, but that's not what we're looking at here. So when discussing glaucoma disease stages, the status of the visual field is often used as the most important reference. I think I've said that from the very beginning. All right. So for GSS, a discrete level study system modified from the Hodder Parish classification has been used for several years. Here you are able to grade glaucoma, okay, the grading scale for glaucoma. And for MD, which is your mean deviation, it is Humphrey, or your mean defect, which is octopus. When your MD is less than 6 decibel, it's glaucoma. So in fact, what we usually do is from low to no, NO glaucoma, you have 0 to 3 decibel, or yes, 3 decibel. While you have from 3 to 6, we call it mild. From 6 to 12, we call it moderate. while from above 12, it's severe or advanced. Not just only use MD, you can also use the visual field. If you have no defects around the central 5 degrees, it's early. And of course, when sensitivity also is not less than 15 decibel around the central 5 degrees. While for moderate, you have this just to save up time. And for severe, just like I mentioned, severe is usually above 12. So these are the glaucoma grading or staging system that you can use. That's a visual field out. So we take note that vital goal for all glaucoma management is preservation of visual function. Visual field is a measure of a visual function that is not captured by visual acuity tests. Visual field testing identifies, locates, and quantifies the extent of field loss. The last to the last is the OCT. You and I also know that OCT is very, very important in diagnosis of glaucoma. Here you check for the reliability indices, if it's reliable, you check for the focal loss volume, global loss volume, the RNFL symmetry, rim area, the tissing through or tissing map, and of course the average fiber thickness. This is how it looks like. We have a whole module on these two, and hopefully we will be discussing it in this bi-weekly presentation. And lastly, gonioscopy. Gonioscopy is indicated when you have a narrow or open angle. You can still find it, and that's when you do gonioscopy to be sure that you are seeing all of the structures that are here. From anterior to posterior, you have a trabecular line, the trabecular meshwork, the scleral spore, and lastly the ciliary band. Ciliary band is the last. You shouldn't see the ciliary band, but if you see the ciliary band, it means that the angle is very, 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 open. In fact, the ciliary band is seen usually when there's a recess or when there's an iris tear. Okay, but at least on the scleral spore, or the posterior, or maybe pigmented trabecular meshwork can be seen in an open angle. But when you don't see any of that, when you don't see any of these structures, then that angle is closed, although it's classified with this system as well. So when you have all the structures seen, like I said, the ciliary band, you have a wide angle. But most time, like I said, you don't see the ciliary body itself. If you see that, then it means sometimes there's a recess, there's an angle recession. When you have see the scleral spore that's open, when you see the trabecular mesh, whether it's pigmented or non-pigmented, then it's narrow. When you see only trabecular line, then it's very narrow. And when you don't see any of those structures, that means that angle is closed. This is how it looks like when you check it. Now, how do we care for open angle glaucoma? This is our focus for tonight. I was saying earlier when I started that every one of us who in this part of the world, okay, we are not restricted, especially for those of us in private practice. We're not restricted in any form, but it depends on the scope of knowledge as it concerns managing caring for glaucoma patients. So how do you approach open angle glaucoma in terms of management? So we're looking at this under two categories: treatment goal and the principle behind the treatment. Now, the treatment goal, as we always say, is to ensure that this patient's quality of life is maintained. They are not burdening some to themselves and to society. Of course, also quality of vision. We're able to see that the quality of vision is preserved, and of course, it shouldn't be too expensive for this patient. We should be able to cope with it because it's a lifetime treatment. You can't be starting a patient on Zalatan, for example. And that will last you for just 2 weeks. So imagine you spending over 50K monthly for just a medication outside all the expenses. So you must be careful to know how to, if Nisopt, for example, is cheaper, can address or give you a target pressure. Why would you always place patient on latanoprost? So the main goal of treatment is to maintain patients with equitable vision, that we have talked about that before. how do you attain treatment goal? Decrease the risk of ganglion cell loss. Remember we said that the ganglion cell loss may be due to some form of metabolic changes within the eye. It may also be due to IOP, tension in the nerve fiber, the optic nerve head that will damage the nerve fiber and of course lead to ganglion cell. So it can come from damage can come from the nerve fiber. It can also come from the ganglion cell itself. Now, either way, you should be able to know it and then find a way to address it. Every glaucoma patient must have a target pressure. There's a scale that we usually use. It's in one of our slides. I'm not so sure now. But there's a scale depending on the severity of the case. So if it's a severe case, you should be able to cut that pressure down by 50%. That should be the target pressure. Okay. So if it's moderate, maybe cut it by about 30%. If it's mild, maybe 20%. That's one of the scales. I've forgotten the name of that scale right now. But that's what I do anyways in the team. So if I see a case that it is a very severe case of glaucoma based on some parameters that we looked at earlier, then I can now know the target pressure to give. There's also a way to calculate it, or there's a formula to calculate target pressure. So you should be able to ensure that this patient gets that pressure. And whatever will take you there, whatever medication will take you there, get it. Okay, so verify the target IOP, monitor for visual field progression or optic nerve damage, and of course adjust the treatment according to the rate of progression. Oops. Sorry, we just interrupted power. No, you can't see me now, but you've seen me a couple of minutes, just a moment. So I'll still continue as the power is restored. Well, I'm sure you can still hear me.
Yes, I can.
Thank you. So, so you consider patient's compliance of, okay, first of all, neuroprotection and blood flow drugs. There are some medications today. What's the name of that medication now? Oh, it's one, oh yeah, rho kinase, yes, that's the name, that's the generic name. We call them rho kinase inhibitors. Yeah, they are the I think the 5th generation anti-glaucoma medications now. Latanopros is the 4th generation of the why this is one of the recent ways. One of its rules is it helps to lower IOP by what's the word? By ciliary what's the word? Just skipping now. The same way Latanopros does. If everyone can remind me of that statement exactly. Okay, if I remember, I'll mention it, okay? But outside that, it also has some way of protecting the nerve cell, okay? From neuroprotection. It has a way of protecting the nerve cell, you know, from some damage. The localized inhibitors are available today, but not very common in this part of the world yet. Also, you should consider the compliance of patients. Make sure that the patient is complying with the medications, and that's one of the problems that makes glaucoma to progress. Compliance. You don't use the medications as a shield, and that results in some form of progression. And sometimes even couple follow-up. So it's really a big deal for patients and even for the practitioner as well. So general approach, once the diagnosis of glaucoma is made, the following general approaches should be instituted. So medical and possible surgical interventions should be instituted to prevent vision loss and prepare quality of life. You educate your patient also. You don't just leave them with their faith. Sometimes they don't even understand what glaucoma is. Now, they're threatening, but those things sometimes will make them sit up because they'll think it's just one of those things. They think it's just one of those things, and they would, pay less attention to disease. So sometimes you let them know that this disease will cause you to go blind if you don't do the needful. So we must educate them. They must understand what it is, and we should also inform them to alert relatives. In fact, I have a patient that managing of glaucoma. He lives in Benin Republic. In fact, do business over there. And of course, when I saw him, his stage was actually advanced. So the first advice I gave him was, please find a way to relocate. Come back to where you have your relatives, where you have your family members, so that in case lightness ensues, you're not shortchanged over there, and all of that. So you must tell them the need for them to be around their families in case any of such things happen. Financial, physical, social, emotional, and emotional burden of glaucoma treatment options should be carefully considered for each patient. So it's not everybody that can afford certain medications. You must ensure that they can afford it. It's in their pocket. It's within even their job. Some of them cannot be doing 3 times a day treatment. They tell you, no, I will forget. My job will make me forget. So you must ensure that you give them something that they can use. Once at night, and blah, blah, blah. Some of them will tell you that once at night I can't do it. I sleep on time. Okay, then you have to use something that you can use. The principle for managing glaucoma number one is a therapy. The objective of glaucoma therapy is to maintain patient visual function. We said that before. You know that there's no cure for glaucoma, but you must be able to slow the process that leads to blindness. Consider also adverse effects and complications. Consider socioeconomic burden. Sorry, I'm trying to rush because this lecture is also for 1 hour, and I don't want it to exceed 9:30 so that I can go. So please, just rush some things, and but if you have a question, we can always ask. All right. So at present, the only reliable treatment for glaucoma is to reduce IOP. I don't want to say sadly or fortunately, but that's it. Sorry, excuse me. Sorry. Sorry, I'm sure you can still hear me, even if you can't see me. Hello, can we see?
Yes, we can hear you.
Okay, sir. Thank you. All right. So we've said that the most important treatment measure is to reduce IOP. And surgeries are usually the last option, although sometimes there are cases where surgery is the first option. For example, a case where you have congenital glaucoma or you find glaucoma in a child, usually we advise that do something to open up those drainage before um, you start using medications, because that child is too young to start medication at that age. So causal therapy must be provided for all treatable causal factors. So sometimes when the glaucoma is due or the increase in IOP is due to a causal factor, you must address the causal factor. For example, pupillary block, where there's a blockage of the drainage due to your pupils or due to the eye. When there's angle closure, when there's uveitis, any of these are causal factors that we can use that you can address, and glaucoma will stop. Early detection is also very, very important, very, very, very vital for glaucoma management. Now, one of the reasons why I said, one of the reasons why you should do that is when vision is lost, you cannot regain it. Right? You cannot regain when the vision is lost. So you must ensure that it's diagnosed on time. And that's why we said early detection is key. So when you see us going for awareness, going on radio show, stress is part. In fact, that's one of the things that can help us fight blindness when it is detected early. So people should know that regular eye checks is very, very key for this condition. Achieve maximum effect with minimum required medications. In fact, one of my interns in school was managing a case and just wrote uh, timolol and bromidine. I was like, how did you, this is even someone's pressure you're not even sure, right? You did, yes, you did pressure, the pressure was within 18 and 21, and we are already giving two medications, you know, double therapy. I have to counsel her for that's not how we start. Okay? There's a way you manage glaucoma. You must start with the minimum required medication that can give you the desired effects. You don't just go bombarding them with medications because you think it will help. Okay. So you must also consider how this medical, okay, for example, if that IOP increase is due to, say, uh, increased secretion, hyposecretion, just like we discussed earlier, it will not be wise to go and start narrowing the angle or giving medications that will that open the angle, so that giving medication that will open up the angle. You know, it's not wise. So you must know what the causal factors or those signs you've seen. So if you observe that it's hyposecretory, then you should give the medications that will reduce secretion of aqueous. While if you observe that what you are seeing there is due to uh, maybe narrow angle or some debris within the angle, then you can do some outflow, something that increases aqueous outflow that opens up the angles slightly to increase aqueous pathway. So these are the things. That's why the mechanism of action is very, very, very key. Adverse effect also, sometimes some patients may be reacting to some medications. You should consider that. You should consider contraindications. For example, you cannot give timolol to hypertensive patients. You can do maybe timotol or some other forms of adrenergic agonists that can help that patient, significantly. You also consider costs and, of course, compliance. I said that before. Selection among drugs, laser treatment, and surgery. Here you determine the appropriate therapy that is based on the individual, determine appropriate therapy based on stage, that's the severity, and also the type of glaucoma. Concomitant use of multiple medications may increase adverse effects and reduce compliance. Very, very true. So remember that the more medications you use, the more prone you are to dry eye, because these medications usually are preservatives or have preservatives. So the more you put bark, which is one of the major preservatives in eye drops, that's the bicolium chloride, the more you put it in your eye, the more you are prone to having dry eye. And most times patients will tell you that each time I use medication, I don't feel comfortable. I feel teary most of the time. Okay? So these are issues you must consider. Sometimes you have a patient that has glaucoma and you also have dry eye. How will you now be able to manage this condition? So there are a lot of things to consider. Baseline data determination. You must check all of these baseline IOP, baseline findings, visual findings. Then you build on that. They serve as baseline, and you can now know if it is working. I mean, if your management plan is working. If you know the baseline IOP, then your medications for IOP should really work. I'll give you the target IOP. If it doesn't work, then you have to change. If you know the baseline visual field as data, if it's worsening after some time, you have to change. After you must be able to know what the baseline is helpful to determine if whatever method you're using is working. It doesn't mean you need to modify or abruptly or change it entirely. All right, now setting target IOP pressure, very, very important. Okay? I think I've mentioned that before. You want to set target IOP plus IOP, you consider the stage, consider That's what I told you earlier. I said it is a severe stage, then you can have reduce the pressure by about 50%. Also consider the level of pressure, that about consider the age or life expectancy, status of the fellow eye due to sympathetic ophthalmia. For sometimes one eye may just be sympathetic to the other eye. You should consider that too, disease history and other risk factors. For early stage, pressures should be within less than 19. Middle stage, as middle stage, less than 16. While for late stage, it should be less than 14. That should be your target. Moreover, based on various randomized comparative studies, it is recommended to set a target rate to decrease IOP from baseline, such as 20% or 30% decrease. We can even get up to 60 or 50% decrease if the case is severe. So if I'm having a severe case of glaucoma and the pressure is 20, my target pressure should be 10. Baseline pressure is 20, my target pressure should be 10. That's what I use anyways in my clinic. Next one quickly. Okay, so these are ways to calculate IOP pressure. So IOP should be less than 21 for normalcy. IOP lower by 20-30% from baseline. That's one way, and this is a formula that we call it the Jamtel formula, can use it to calculate the target IOP. These are under guidelines, is the American Academic Guidelines for target IOP. For mild stage, you use at 20-40%. For advanced stage, you use at 40%. I do 50% anyways. So for 50%, you are still within the range. For normal tension, reduced by 30%. For ocular hypertension, reduced by 20%. For open angle, target pressure should be within 14 to 18 less of mercury. Advanced glaucoma is to less than 15. And for those ocular hypertension, target IOP should be less than 20. How to use target IOP? Okay, please permit me to run. I just have about 7 minutes to stop this class. Compliance with glaucoma drug treatment. Non-compliance is an important factor. We've said this before. So if you want to improve compliance, you must be able to explain the disease to the patient very well and keep your treatment as minimum as possible. Don't give multi-therapy when you can do monotherapy. Please. Now, like I said, you can manage glaucoma medically or surgically. Medically, we can use medications, sympathomimetics, sympatholytics, vasopressor and all of these. It can also be systemic and topical. You and I know all of them, and of course, your hyperosmotic medications to reduce the water that is within the eye. Carbonic anhydrous, this can be systemic. As seen in what's the name of that medication again? Dianox, okay, Dianox. So, of course, which is supplemented by your slow K due to potassium loss. Then surgically, you could use your argon laser, although argon laser trabeculoplasty is not as common as you have to do. Rather, it is replaced with your SLT, which is selective laser trabeculoplasty, which is much less invasive and it can be repeated. For argon, it's more destructive, and a surgeon will not want to repeat this procedure on you. But for the selective, which is much more common, you can do that multiple times. You also have a trabeculectomy, which is it's in vivo. You open up the eye and, of course, use your knife to cut some part of the iris out so that fluid brings out more. Treatment procedure, your psychotherapy, your cyclolaser ablation, uroidectomy, or what you call a uroidectomy. That's cutting some part of the iris out of fluid. So medical agents, mentioned all of this before, we all know these medications. Time to watch, I can stop in a short time. Prostaglandins, which is one of the very, very most potent medication for IOP control. We have the latanoprost, travoprost, and the tafroprost. The tafroprost also reduces IOP around that. You don't use it when the patient is having contact lenses. Why? because one of the side effects is that it makes the eye red. And of course, contact lenses also can cause that. You don't use it on contact lenses. If the patient must use, you must take out the contact lenses for that period. Side effects are pioneer stinging, burning, organ sensation, and all of this. One of the good side effects is that it makes your eyelash grow longer, and ladies usually like that part. How do you use it? Use it one drop daily, usually at night. The beta receptors, selective and non-selective, where you have the timolol, the tanzolol, um, which is usually an option for patients that are hypertensive. So you use that supplement the patient's hypertensive, supplement timolol. These are the side effects. So we'll just have to run. We have your carbonic anhydrous inhibitors, like I said, it can be topical, and of course, it can be systemic, not topical. You have your astaxanthin as seen in diamond, that's sorry, systemic. You have astaxanthin as seen in diamond, and of course, you have your dosilamide as for topical medications. These are some of the side effects, and I mentioned that earlier, it reduces potassium and sodium in the blood, use the blood, and that's why you supplement with your sodium. The alpha adrenergic agonist, you have a epinephrine, citalopram. Now, this also helps decrease pressure by about 25 to 35%. Okay, the past supplementics, these are like your coordinates, help to constitute the pupil, and this is what you use to treat, basically use it to treat your angle closure glaucoma. We look at that later, that last part we look at before we go the next meeting. Sorry, I'm rushing. Osmotics here you use it to reduce the level of fluid within the eye, and sometimes the contraindication is that we don't use it for patients that have chronic renal failure or cardiac failure. Medical therapy, rule number one, start with monotherapy. I think we said this before. This will help the patient financially. You don't combine medications for start. So rule number one is start with monotherapy. So when monotherapy fails, then you can now, don't even go to multitherapy yet. Monotherapy fails, try another monotherapy. You try another medication. So when you try another medication that you can now use, and it fails as well, that you can now use double. You can now try double therapy. When double therapy fails, try another double therapy before you go to multi-therapy. You don't just go straight. So if monotherapy fails, initially try another monotherapy. So use another drug. Then of course you can now change from mono to combination with mono, the second mono fails. So when you are combining medications, make sure you don't combine medications that will have that will be a problem to the patients. Okay, so you must combine medications that when they are used together, they don't cancel out their effects. Very, very, very important. Wow, so baseline without treatment, establish a target IOP, commence initial treatment, where IOP target is achieved, then you continue. If you continue treatment, or if your IOP target or your target IOP is achieved, you continue with the medication. If it's not, then you change. That's what we're saying so far. These are enough looked at what I've said so far. Now, how do you manage with closure glaucoma? Like I said, firstly, reduce IOP by using some form of medication, then use period. General recommendations will be that one, I've said this before, monotherapy if it fails, don't change, don't use double, change to another monotherapy before you can start using combination therapy. How do you follow up your patient? Follow up patient, like I said, have a baseline at the beginning there. From your baseline, you can now see if there's any change as you do the follow-ups. Adherence and compliance, I've said this before. Compliance is very key. Adherence to dosage and all of that is very key. So we must be able to explain this to our patients. Education is very, very key. And of course, if you cannot, then if all of your plans are failed, please refer for surgery with medications. So you don't need to open up the eye these days. They have non-invasive surgeries like your SLTs that can help to take the same form of management to your patient. Now the questions are, should you as an optometrist diagnose glaucoma? And the answer is yes. Should you as an optometrist manage glaucoma? The answer is still yes. However, that depends on your expertise and your skill. Decision is yours. Practice. Thank you. Use what extra minutes. I think I apologize for stopping away from it. So it's time for questions, contributions, if you have any. So I still have Dr. John, Dr. Ndezi, Chairman, Dr. TJ, that should be just Dr. Justin himself.
Okay, so the questions I wanted to ask, you already answered them. I wanted to ask how we derive our baseline IOP. But then you've already answered.
Target IOP. I think you meant to say target.
No, not target IOP, like baseline IOP.
The baseline IOP, okay. What did you hear me say about that?
Okay. Based on the knowledge that I have, I know when you speak of baseline is the result has much lesser errors and is easily reproducible. But then I was now trying to think of how to derive how you get the the baseline IOP. Then you now brought out the slide where you said the baseline IOP is the IOP of the patient without any treatment. So
Exactly. So that's it. So the pressure you get when you diagnose glaucoma, when you've not placed a patient on any medication, that's a baseline IOP. Then of course target IOP will now be what you want to achieve as it concerns that patient. Thank you very much. Any other question?
Hello, very good evening, everyone.
Yes. Just in.
Yeah, I'm just.
This man, you can always deceive us. From TJ now, we are just in.
But first of all, I appreciate Dr. Osazee for a really exhaustive, down to earth, deep, how what is this word? What do we want to do? Able to even encompass, simplify or demystify the way glaucoma is being perceived in simple terms, and within the less than 2 hours of his presentation. Thank you very, very much, Doc. God bless you. You've said everything. Mine is just to add some contributions and also the way forward and why we are doing this type of training, this seminar. Although it's quite unfortunate that we just have very few persons attending this lecture, I see it from the perspective of possibly the way it's been, if glaucoma is really practiced properly as it is in developed clime, I would have expected more people to be in here to learn from what you have just said today. And I'm glad that even with the few persons here, we are able to take in new information or refresh our information knowledge base or what we know and how we can improve it in practice. So my contribution is in three folds. So one one is based on this is following up on the study I did among optometrists in Nigeria, comparing the glaucoma management with what is obtainable in Nigeria, what is obtainable in different climes. And the practice is 10 years behind what is already being done. Especially when we are looking at how it's being practiced by the average optometrist in Nigeria. And the good news from that study is that many of the people that reported well within the questionnaire about how they practice the glaucoma in itself were persons that have come across FOM teachings on uh, glaucoma lectures, IOPs, and the likes, which shows that yes, Dr. Osazee, so can optometrists practice no diagnose glaucoma? Yes. Can optometrists treat glaucoma? Yes. But not every optometrist should be given the license to treat glaucoma. Not because you're an optometrist, now based that because you just graduate from the university. Yes, I can treat glaucoma. What I would recommend, I would going what to emphasize is that you need to further take more courses or professional training like what we are doing here to give you more in-depth knowledge of what is happening at the management of glaucoma in recent time. That is what brings me to my second part of clinical guidelines of glaucoma. In the UK, there is this a lot, they have this referral system. Everybody sees the disc, poops, uh, possibly is glaucoma referred to the hospital. And they are very false positive, and let me see false positive, false negative referrals that now the hospitals, the NHS have brought out. They did what we call the NICE guidelines that tell you before you make any referral for glaucoma, even before you treat glaucoma, there are certain things that need to be done before you can even diagnose glaucoma. First, there's what we call repeat measures. Glaucoma is a progressive disease. So if it's a progressive disease, I've seen a case, a patient that, yes, he had an injury when he was young as a child in Nigeria there. He had he was a Fulani man, had an injury. The pressure, he did not take care of it, blow to the eye. The pressure built up, affected the back of the eyes. He grew up like that. Unfortunately, he went to one clinic. They saw the back. They say, "Oh, see, you have glaucoma. The optic, this everything is bad." They placed that guy for many years for many drugs. He's still using drugs. Nothing happened to the other eye, but still the same eye is still using drugs, even with the pressure being low. And what did they say? They said it's glaucoma that is treating. But from what in when I now why am I making this reference was to go back to what is being done. Yeah, there are traumatic conditions that could cause an injury to the eye that shows optic disc characteristic of optic disc excavation as a result of secondary glaucoma and stops when the eye has been, everything pain resolved during that go through that inflammatory phase and the pressure is low. Do you keep treating such patients if you see that there is no more progression and the other eye is not affected? It was a table of thoughts that what they done, as I said, repeat measures, look at what we call low risk and high risk individuals. When you are able to get the low risk and high risk individuals, then you are able to begin do your treatment. And going forward in recent times, the first line of treatment now is now what we call the SLT, the selective laser trabeculectomy, which has been shown to be much more effective and has the same effect, same uh, what do you call efficiency with taking drugs. And because of the level of pigment, especially when the study was done, when they say there's a likelihood for this thing, the trabeculectomy, trabeculecplasty laser treatment could have been, you know, it's not working. Let me use the word working properly. They've now advocated that there will be two sections, where the first time you do it, then another period of time you do a second section to make it work. So it helps. It's like the first treatment plan. But are there cases where this may not be as useful as taking drops? Yes. That is where able to identify the patient that will require drops is very, very important. For instance, in the case of a person that have a uveitic glaucoma, or a person comes in and there's likelihood that giving the prostaglandin could be contraindicated. As a result, one can also require to do other forms of drug that will not, cause further harms than good. Overall, now comes down to what we call. Remember, we also did today's study. We talk about the close angle, and here we now have what we call the Pax plus and the Pax minus. The Pax plus is what we call primary angle suspect and primary angle closure suspects. So someone can be a suspect. For instance, if you check the Van Herrick, which bring me back to the study that was done for our optometrists in Nigeria. Many optometrists don't know how to do Van Herrick procedure technique, which are looking up that possibly going forward when we are doing glaucoma management teach in practice face to face, there will be need for helping optometrists to know how to do this slit lamp. As simple as Van Herrick technique is very crucial since it's a surrogate to using the gonioscopy as it were. However, uh, good news is that we've been able to have sophisticated equipment like the OCTs and the likes. And with that, with target pressures, we're able to see how we're able to manage these patients rather than also see that glaucoma is also, we also look at, consider the patient's quality of life. But at this point, I would say, well done, Doc. You've exhaustively said everything, and I'm glad that I joined this meeting today. Thank you very much.
Thank you, dear erudite platinum mentor, Dr. Justin. God bless you, sir. Thank you so much for the very, very valuable contributions. Okay, so any other question or contributions?
Okay, thank you very much, Dr. Osazee.
Thank
Dr.
you so much.
Justin, thank you for your contribution. I was able to pick out one or two very new knowledge and information. Thank you so much. Okay, I would like to talk about, or rather, it's more of a question though. When you talked about, do I call it grading using the mean defect? I was always under the impression that greater than or minus 6 decibel was, let's say, moderate glaucoma. I usually do 0 to -6, then 6 to 12, and then greater than 12. I don't know if you can throw more light on it. I heard you mention 3 or 4 when you were talking about it, sir.
Okay. So what I usually do is
Yes, sir.
From low from NO, okay, NO to low, LOW. From no to low glaucoma, you have 0 to 6 decibel. So that low then means mild. All right, so that's why the slide actually mentioned that when you have from less than 6 decibel downwards, you are having early glaucoma. So it can be early glaucoma, it can be no glaucoma at all. Then from 6 to 12, then you're talking about moderate glaucoma. So you have mild glaucoma that is from 6. Okay, better put, some materials will tell you 0 to 3 is not glaucoma. From 3 to 6 is mild glaucoma.
From 6 to 12 is moderate glaucoma, while when you have above 12, it's severe. But just also mention that, remember I said, it's not only the MD you look at, okay? You must also look at the areas that there's the defect. If you have areas that is not around, if there's no defect around the central 5 and you're having it maybe at the periphery, that also qualifies, or that's also another criteria you use to see if it's early or moderate or severe. Okay, so outside the mean deviation, although your question is on mean deviation, and I think I've stressed that. So once again, 0 to 3, no glaucoma. 6 to 3, 0 to 3, no glaucoma. 3 to 6, mild or early glaucoma. 6 to 12, moderate. Then above 12 is severe. I don't know if I answered your question, sir.
Yes, sir. Thank you very much, sir.
God bless you,
Also,
sir.
sorry to add
Isn't
to
that
what
okay?
Dr. Osazee has said. It's just my own opinion. Is case studies and opinion. So you can take it with a pinch of salt. Okay. The the classification system using the MD value by whatsoever. I say for example, what is his name? Hard up tap classification as it were, is in relation with the visual field. Okay. Visual field, sometimes you can have certain subtle changes within visual field, and when you see the when you do your, what we call that, pre-pragmatic assessment of the fund of the of or the fundus, you know that this is what you are seeing here is not, it's 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 quite vast than what is expected in the visual field. As we said earlier, when it becomes manifest in a visual field, possibly up to 40 to 50 or even 60% of these nerve fibers have already gone. So at that stage, even though it's appearing as mild on a visual field, it's much more gone advanced in the way you check the optic nerve assessment. That is why with when that is why one of the key one of the key diagnostic way of even assessing the severity of any of glaucoma is for the clinician to do a slit lamp dilated biomicroscope with your Vokes. Although yes, we use our ophthalmoscope, we don't get the real detail of what is happening at the back of the eye. Even when we do our fundus image, which is good for what we call it, uh, 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 documentation. But when you're able to look at it stereoscopically with your Vokes lens, you see a lot of information that guides you and tells you what is and what is not. And it also helps you to differentiate between certain conditions that will mimic glaucoma, which can also be masked using our visual field. Remember, the visual field, especially the MD, there are certain factors that can also influence the MD values. I will be thinking that, oh, it's moderate, oh, it's today it's looking moderate, tomorrow it's looking severe. Because some of times, if these patients are aged, there's a certain level of cataract that comes in, and eventually, what is supposed to be called a mild or case, we are labeling it moderate. So overall, the visual field in itself is just a tool to just give us more information. And we expect that the most important thing when we are looking for this MD is to look at the PSD in itself and look at the pattern of how the level of scotoma changes. And over time, you are able to also compare. Remember, if we are also looking at the type of, if we are going to do trend-based analysis, and if we don't have the equipment to look that, we can, then we need to be comparing the patient visual field of of now with their the patient will now become, once you've gotten your baseline, the patient now becomes your the you now begin to compare the patients with by itself with its own with its own type of what is the word I want to use, their own records. So it gives you a better level of understanding about the progression. So that's just my thoughts, my contribution to this. Thank you.
Thank you very much, Dr. Justin. God bless you for that contribution again. So I hope we've thrown a lot of light on that question by our chairman. So if you have any other question, you can raise it now, or otherwise we can close the meeting for tonight. Any other question?
Okay, Doc, I wanted to ask, at what, because we rushed the management part, at what point will you give the systemic medication for a glaucoma patient?
Okay, very good question. Sorry we rushed that part. So we have always said that, and remember the systemic medication that are available under two groups. We have the carbonic anhydrase inhibitors and also the hyperosmolarity medications. Now, we don't use those medications except, we have a pressure that is extremely high that we need to crash down as quickly as possible. So when you're having a pressures that topical medication may not be able to address, for example, having pressures of over 40 mm of mercury, you may not be able to achieve immediate pressure drop with topical medications. And that's why you have to go systemic so that you reduce it as quickly as possible. So in my opinion, when you are having extremely high pressures of over 40 mm of mercury, that's a very good indication for using systemic approach to address the pressure change. I don't know if that is clear.
Yes, it is. Thank you, sir.
God bless you. Okay. Any other question? Contributions?
My question is, do we continue to allow optometrists manage glaucoma when they don't have the right tools?
Well, that is why I put at that last slide that the choice is yours. My counsel from the very beginning was there are two things that we consider when you manage any disease. Number one is the scope of practice. The scope of practice helps limit everybody. So if it is not within the scope of practice of optometry, you shouldn't delve into it. Otherwise, you may have legal issues. While the second will be the scope of knowledge or expertise or skill. Now, if that disease is not within what you can manage as an individual, why do you want to dabble into it? That can also even put you bring you legal consequences if you're not careful. Because you can manage binocular vision or myopia and you fail to give the right medications. Today, myopia control is what is in vogue. Every family, everybody knows myopia control. And if at this age, as an optometrist, you don't engage your myopia patients in this regard, you are at risk of facing legal consequence one day. Because if you just do the regular single vision and the patients keep coming to you 1 year in, year out, and they started with -1 and after 5 years, they are already using -8, then you explain to the parents why you did not use myopia control approaches that are available to you. So it's not a matter of whether you know if it's within the scope. That's just one of it. If it's within the scope and it is beyond your level of knowledge or skill, please refer. Don't manage what you cannot do. Refer to either the ophthalmologist or a competent colleague that you know can handle the case. The most important thing is patient's care. And if we consider that, then we'll not look at ego or some form of, oh, they may feel I don't know anything. If you don't know anything, build yourself to know. And that's one of the reasons we are having this bi-weekly presentation. So I hope I addressed that question, sir.
Yes, thank you. Because what I'm saying is because my chairman is here. My
Yeah.
chairman.
I'm sure the chairman understands that
Yeah,
fact.
my chairman
I
has to put
understand
things
perfectly
on.
well, sir.
Yes, sir.
My
Thank you so
chairman
much.
has to help us to make sure that we drive this message.
Yes,
So
sir.
we need to start from home among
Absolutely.
us. Yeah.
Absolutely.
Yeah.
All right. Thank you very much. I think we have stressed this. I don't want us to get into 10 o'clock. All right. So I want to appreciate every one of us for joining. Please let's encourage our other colleagues. Let them know that what we are dishing out here is important for them to become better at what they do as optometrists. So encourage them, and you also try to be very regular with this presentation. So we're having the next one in 2 weeks' time. Hopefully, God spare our life. We'll be here again, and there will be another very interesting presentation. You have the list. I mean, the schedule is already posted on our platform. You can check it out and know what is coming next, and of course, plan adequately for it. Thank you very much. My chairman, I appreciate you, sir, for giving us this platform. And I want to appreciate every other person. Dr. Chioma, you have been here from the very beginning. God bless you, ma. And of course, our dear Dr. Justin. Oh, Dr. Kelechi just joined in. You missed a lot of Dr. Kelechi. Good evening anyways, and thank you for joining. And with that, I wish everyone a wonderful night rest and a blessed week ahead. Thank you very much. Good night, everyone.
Thank
Thank you,
you.
Good
Dr.
night, sir.
Osazee.
Good
Thank
night,
you.
Doc. Good night, chairman.
Good
Good
night,
night,
Doc.
Dr. Justin. Good night, sir.
Good night,
Good
sir.
night.
I'm loyal, sir.
Well.
Good night, Dr. Justin.
Good night, Doc.